So now we're going to have the discussion period. If I could have the slide, yeah, perfect. And we have a microphone there. You can either text us your questions for the panel, or you can come up to the microphone, or just raise your hand and we'll get the microphone to you. I'd like to begin by asking Elisabeth Benham, that was so inspirational. Maybe could you have a conversation right now with Noel Bairey Merz, she is really leading the way here in the U.S. and internationally in women's heart health. How can you guys work together to inform the community of women about heart health?
Well, Dr. Noel, would you love to come and speak at the California BPW conference? The date is, I think it's May. It's middle of May. It's going to be in Minden, Nevada. Not too far from LA. So we would love to have you. That's the whole California Federation is number one. And certainly perhaps you might consider in your calendar in Orlando, where we have our national conference and a conference for the North America region, to do that as well. But the other thing we might ask you is if you could give us some publications that we could have a health corner in our news. We have e-news that goes out every week and a newsletter that goes out monthly electronically to all of our members. It also can go around the world. If we could have just some of your previous writings or anything, we would include that and just begin a campaign of raising the awareness constantly about heart health, either statistics or whatever you think might be really important for us to focus on.
Yeah, I would welcome this, and I would also wonder if we shouldn't discuss partnering with Women Heart, which is our national advocacy of women living with heart disease, and they have chapters in every state now. So similar to your clubs, I would think that there would be local representatives that would want to work with your representatives, and I think that would be just a natural alliance with this initiative. The last thing I would say is I wonder, because of the clear advocacy that your group demonstrates, if we wouldn't want to also partner on advocacy, which is at the not only at the local, state, but at the national level. We have an above average number of women in Congress, and there are expected to be more in these midterms. And this has worked in the past, and with a very strong partnership with an organization that has selected this as a topic, I think it would have to succeed in furthering it's not just research, it's all issues of access to cardiovascular care. A lot of the issues that we're debating now about healthcare really disproportionately affect women. And it's unfortunate against the leading cause of death. So I think we could do some nice work together in advocacy.
Beautiful, wonderful.
Thank you, yes.
While you're at the microphone, Noel, there's a question for you from the audience. It's about fish. Is all fish Mediterranean diet friendly?
So this is a great question. There really aren't any bad fish. For example, you may have been taught that shrimp were high in cholesterol. That is an old wives' tale that was true at the time, the way that they assayed cholesterol. But it's not. I mean, so shrimp are fine, oysters are fine, clams are fine. If you want to spit out something that you think is of concern, let me know. But the one thing to be prudent about are the meaty fish, so the swordfish, the tilefish, and the shark, and then the albacore tuna, the white tuna. These are predator fish, and they have relatively high levels of heavy metals, mercury, arsenic, and lead. And you will see on our Food and Drug Administration, FDA still looks at our food, unlike our supplements, that those fish, those four categories of fish, pregnant women shouldn't eat, period, and children under the age of 2 shouldn't eat, period, and then after that, no more than once or twice a month to consume those fish because of the heavy metal and the toxicity. Swordfish, tilefish, shark, and What was my fourth one? Albacore tuna. So the red tuna is okay. It's those big, the ones that, well, the problem is the predator fish eat a lot of little fish, and then it is stored in their fat. And when you eat that lovely albacore tuna, you get those heavy metals.
And of course, then there's those fugu fish that the Japanese eat. And if it's
Right.
not cooked well enough,
Right.
that can be bad for you too. Another thing is the fish, fish sticks that you get at McDonald's probably aren't terribly good for you.
Well, anything that's deep fried is...
It's the surrounding portion.
Exactly. Anything that's deep fried is not inherently healthy for you. Yet, there was a randomized controlled trial done by Dr. Burr in the UK, and they advised, it was one of the earliest dietary trials, and they advised Northern Londoners to either eat fish and chips, which is deep fried, I think it was 2 or 3 times a week, because the usual was you just ate it on Friday, right? Versus usual. And they did lower cardiovascular disease with that advisement. So it might be better than a hamburger.
I think there needs to be a confirmatory study there. But nevertheless, one other fun fact about fish is that fish don't make fish oil. You probably know that, right? Fish don't make fish oil. Omega-3 fatty acids, docahexanoic acid, icosapentaenoic acid, those are the healthy omega-3 fatty acids, and they actually come from krill. So the krill, the plankton, make the fish oil. And the little fish eat the krill, the big fish eat the little fish, and the bigger fish eat the big fish. And so that fish don't make fish oil. The other thing is that farmed fish don't have a lot of omega-3 fatty acids because they don't get to eat the krill.
They don't get to.
They
That's
eat
right.
the grain that the farmers, and corn, and they don't have much omega-3 fatty acid. Anyway, great question. Another question from the audience here.
I have a question about access to testing. How is the payer community reacting to trying to get this kind of going more where women are being tested and having cardiac tests, Medicaid, Medicare, and private payers? Are you seeing any blowback or any increase in allowing payment for it?
Well, one of the tenets of the Affordable Care Act was that everyone, similar to Medicare, could get a basic screening cholesterol, and that it wouldn't be back charged, that it would be considered part of general health care. And so that's one of the many things that as we roll back the ACA, women will be disproportionately affected because they're less likely to be tested, and the OBGYNs are often delivering a lot of their primary care. So this opportunity to go see a general doctor or even a nurse practitioner and just do these basic things is important to protect. More advanced testing is, covered equally in women and men, but it's less often offered to women because of this perceived idea that they could never have a Hollywood heart attack. So once you get insured, there are no health disparities. And once women get over the age of 65, they're better treated, partly, I think, because cardiologists get it that this is an age-related disease, and women and men will be equally insured in Medicare. So it's an example of if we just can make sure that women have insurance, and then we can help our physician workforce understand that women can get heart disease, they'll do the right testing.
Dr. Zoghbi, do you have a reaction to that about access to medical care?
I agree with Noel. I think this is an issue. The issue is our health care, and if you clamp down on ACA or the Affordable Care Act or Obamacare, unfortunately the health care access and health care equation has been politicized. If you get out of the United States, this is not politics, it's just pure economics. Here it has been politicized, unfortunately. And I'll tell you that we're in the most powerful country in the world, the richest country in the world, yet we don't provide preventive services, to our population, be it men or women, it doesn't matter. So that's a major issue that we have in the United States. The other major issue is, access. If you don't have insurance in this country, I think you're pretty much doomed because the healthcare costs are incredibly high. And I think we have to address that as a population, all of us, because it will affect women more than men. And you know, if this is what we care about, which is good health, good longevity, and good quality of health, should be our top priority in this country. So
I don't want to, thank you, Dr. Zoghbi. I don't want to leave the panel without getting some remarks about nature and spirituality. So what I'd be interested in what trials are going to be done here. Can you tell us a little bit about, you mentioned that we were going to have a trial at Methodist on how nature might help cardiovascular health, or maybe Bina wants to address that.
I'd like to ask Dr. Cash to address that, if you don't mind. I could say it, but she could say it better. Dr. Cash?
Sure. So, thank you. We're working with Dr. Kurrelmeyer. Is she in the room? I think she was here. There we go. We're working with Dr. Kurrelmeyer to design an experiment in her clinic. And right now we're developing the protocol for the IRB application. But basically the idea is it seems like Dr. Kurrelmeyer's clinic, the patients coming through the clinic spend quite a bit of time in the exam rooms. So we have them captured there long enough to expose them to an exam room with nature and light versus exam rooms without nature. And therefore, we have a nice experiment where we can look at the effect of nature during the exam, pre and post biometrics, in looking at really identifying that effect of nature on patient outcomes. That's the summary of that experiment. Looking forward to working with Dr. Kurrelmeyer and then expanding that hopefully next year, where we're looking at patients who we can recruit to participate in yoga, so mindfulness training, not as much physical exercise, within a closed yoga room environment, so in a physical environment versus outside in a park. So we have some plans.
Thank you, thank you. Great, that sounds wonderful. It'd be great to have some objective data on that. I want to, the one Cynthia mentioned about going for a walk in nature with a glass of wine, I'll volunteer for that one.
Yeah, I'm going to be in that trial every day.
So,
what the outcome is.
do we have another question here, yes.
So by this time, I think you all know that we are twinning between the BPW club in Rome and the BPW club in Houston. And so in order to get prepared for this very important event, we got to prepare because we, as Lisa told you, we are supposed to prepare groups which are then responsible to be more prepared than others about awareness. So to collect information and everything. So what we focused on is mainly the importance of nutrition. And because of the Mediterranean diet, we are very good prepared about the value of olive oil. And so if you want to join when we will have our 90th anniversary in Rome in January the 8th next year, and our twinning will be going forward, this will be also one of the major topics we can bring you value in this Bridget project. And so we are listening and we are bringing back. We are bringing back a lot of information and we will check those that we already have. We have a law in Italy regarding gender medicine. But also, maybe you know that in Italy we have a different healthcare system. It's a public healthcare system, so we are not so much depending on private assurances, which is a different approach to healthcare. And the question that I had for you, because I was curious, because unfortunately we see a trend in Italy going back to the necessity to have an incremental private assurance to cover some cost because the government is not going to do it any longer. How are you looking at health as a right for everybody? Because this is also something that in our sustainable goals objective we have to work on. And I don't think we can be a healthy country if we don't look at the whole population and not just on the ones who can afford to have a private healthcare system. Thank you.
Bill, do you want to address that?
I could start. I mean, this is a difficult question and touches on so many issues, but this is a big debate in this country. And part of the reason that you see the outcome of this is this country has not yet come to grips with whether healthcare is a right. So you see a lot of divergence. Ultimately, the question is, in a country that can afford many things, I'll tell you what the United States, and I have a feel about the global issues too. In the United States, we spend about 18% of GDP currently to healthcare. That's the highest in the world by a magnitude. It's not like, we're just number one. We are number one. And nothing to be proud of, because the outcome of our expenditure is not as good. We're the lone star, not Texas, but we're the lone star where we spend so much money, yet our outcome of patients, meaning longevity, quality, et cetera, infant mortality is not as good. So we have to change our approach here. We haven't come to grips with that because, as I said to you, it is very politicized. Other countries have come to grips, other developed countries have come to grips with whether it is a right, yes or no. Actually, the vast majority of developed countries have said it is a right, meaning that we will provide health care to the vast majority, if not all of our population. There is a happy medium somewhere in between, I think, at least in my opinion. Since we're spending 18% of our GDP on it, we're spending it in the wrong places. We know from data research that at least 1/3 is wasted one way or another, whichever way, economists you can talk to. So you could rebalance the equation to still provide health care to the vast majority of patients, not be too costly for you if you know how to deliver it. Most likely the best systems currently in the world, and they are predominantly in Europe and Japan at this stage of the game, is that you provide health care to all the patients, all the population. I wouldn't say patients, because preventive care is very important in it too at the same time. And you supplement it with private insurance. And I'm concerned of your trend because of money is where the money is, meaning that you start pulling down on what you provide to all individuals and you start supplementing it with high cost, private insurance. But the best systems so far have been, you provide a blanket, with some, you have to have patient engagement. And nowadays we know how to engage individuals. You see what I mean? You make them accountable and you give them incentives to be healthy. If your premium goes down or whatever it is, your cost goes down if you do 10,000 steps and if you check your pressure. And, so you have to work in partnership as opposed to just provide it as a right, but at the same time, be mindful of cost. And it is, in my opinion, is definitely a right. The question is, how do you roll it out to the population? That's my opinion.
Well, I can add to that the United Nations, of course, is focused on human rights. And currently, the 193 member states of the United Nations, it's 193 countries, have all agreed to the 2030 Sustainable Development Goals. They've all signed on to it. That's 17 of them. One of them is on health. The others are on poverty, education, and empowerment of women, and so on. So the health part of the SDGs is something that we can certainly advocate on, because it is agreed upon that it is a human right. Now, as far as insurance payments and governments and payments for those kinds of things are concerned, that's, of course, much more complicated, as we've just heard. But I think the advocacy really works in making sure that basic health should be approved and given to every human being. And I think that's something that we have struggled with in the United States. It is clearly not acceptable at all. And it's a tough problem for us, but I think it needs to be pushed, and women can do it. And we've done many successful things legislatively, as you have, Dr. Noel. And I think we just have to take up more responsibility in this and go for it with our legislatures. So we can, again, go to our legislatures and keep pushing on basic health requirements for everybody. I think, and this is just politics and economics, and I think, the insurance providers used to do a lot of health advocacy. I mean, they were doing seminars on, how to keep your keep you healthy and your diet and things like that. But they don't do too much of that anymore. And I think it's for profit. They're just for profit, and health should not be for profit. That is just something that shouldn't be done in any country. So we have a lot of work to do, but I think we can keep at it. And certainly one of the routes through the United Nations is through the Sustainable Development Goals that we all focus on in our countries. And we can go to any of our member governments, the legislatures, and keep advocating there.
That call to action. That call to action is a great way to leave the panel discussion. I want to thank you, my panel discussants, and for the audience participation. Thank you so much for that.